so much, ma'am, for your wonderful presentation. So our next session brings two critical domains of ophthalmic care, that is glaucoma and cataract, conditions that frequently coexist and demand careful individualized surgical planning. So it is my pleasure to welcome Dr. Bhaskar Jha, glaucoma specialist and a cataract surgeon, for his presentation on selection of intraocular lenses for cataract surgery in glaucoma patients.
So I'll be talking about IOL selection in glaucoma patients. Usually, we very commonly deal with glaucoma because they say that 1 out of 5 cataracts operated have glaucoma or ocular hypertension in some form, which may or may not be identified pre-op. So cataract surgery provides an excellent opportunity to enhance the quality of life of patients with glaucoma. And advance in intraocular lens technology can provide greater spectacle independence in selected patients with maximized quality of vision. Cataract surgery these days is less of a rehabilitation and more of a refractive surgery because most of the patients have a higher requirement of intermediate vision, and we also call it like premium IOLs. And premium IOLs are like mostly required by patients for the intermediate vision or quality of vision because the use of the digital devices. So both cataracts and glaucoma are condition that increases with age. So changes in glaucoma that influence the IOL selection. So there are various changes due to disease per se. One of the most important thing is that patients with glaucoma have reduced contrast sensitivity, and it's very proportionate to the structural change. So linear relationship between mean deviation and the contrast sensitivity. Higher is the MD and worse is the contrast sensitivity. So the dictum for treatment or management in glaucoma is that any intervention that reduces the contrast sensitivity is to be avoided in glaucoma patient because they are associated with dysphotopsia or photic signs. Other important changes are that glaucoma patients usually have a poor pupillary dilatation than non-glaucomatous patient, and so this may hamper the performance of pupil-dependent IOL technology, especially in old age multifocal IOLs. And still in our part of the world, we do a lot of multifocals, so we have to be quite careful. And other important change being pseudo-exfoliative glaucoma, which is associated with poor pupillary dilatation and jonular weakness, and this may require CTR intraoperatively, which may have gone unidentified while pre-op evaluation. So pupil size, does it matter? So now the newer things is that aside from extremes, no, because of the advancement in the newer IOLs like VVT or like Panoptics, because these are diffractive platforms, so we don't need the pupils to be very well dilated. But still we have to be very careful, especially in angle closure glaucoma, which the disease itself affects the iris. Other very important aspect is the ocular surface. So the tear film is the most important refractive surface of the eye, and usually the beauty of glaucoma is that the patient comes in asymptomatic. Patient just walks in, we send them back with symptoms because we start them with multiple drops, and we do gonioscopy, we do regular intraocular pressure examination. So this is to be very well identified because it also affects the pre-op measurement of the IOL powers and also the performance of the lens post-operatively because of the reflection of the light caused by the poor tear films. So this is just a image showing the patient with glares and halo with OSD and without OSD. So refractive changes in glaucoma patient, earlier we used to talk because of the commonly performed incisional surgeries, but these days due to the modern day glaucoma surgery mix and SLT, they hardly have any astigmatic change. But while performing combined or independent trabeculectomy, we have to be very careful regarding the astigmatic change while prescribing the IOLs to the patient. Then the most commonly asked question by patients today is that, do patients with glaucoma deserve to have their presbyopia managed? The answer is yes, of course. it depends upon the stage of disease which patient comes to you, as well as the severity of the disease, etiology of the disease, and age of the patient. So this is a guided progression analysis. It shows that the patient has a stable glaucoma, early glaucoma. And this is again a GPA showing a patient with moderate to severe glaucoma, some signs of progression on GPA, both OCT and SBF. And this is a form of severe glaucoma. Usually most of the patient comes to us at this stage because it usually goes unnoticed. But a careful identification and diagnostic may help us with this. And this is very rare in our practice. So while planning a cataract surgery, the patient may have normal vision, the patient may have a moderate disease. So we have to plan according to what would be the trajectory and identify the risk factors. As all speakers were talking about the medical legal aspects, especially we glaucoma surgeons are at risk because we tell them glaucoma China and next year after they come back to us. So before surgery, we have to evaluate what is the stage of glaucoma, how is the IOP control, adherence with therapy, optic disc appearance, RNFL and ganglion cell analysis, the visual field loss, and the risk factor for progression. Because the cataract surgery is being done for the future, more for the future and less for the present. So IOL options, how to choose the right lens. To select a correct lens, we need to understand the benefits, risk, and safety profile of each lens in relation to pre-existing glaucomatous change, visual expectations of the patient, patient motivation, occupational and recreational visual needs. The most important to date is occupational and recreational visual needs because the day you operate the patient, even the severest glaucoma patients will expect that the next day they see a very bright light after you implant a IOL. So the wider option available is monofocal lens. Monofocal lens is an option for all stages of disease because it's the safest, it has the longest track record, providing excellent distance vision when aimed for emmetropia. This lens requires spectacle correction for intermediate and near activities. We can target a monovision for these patients, but the monovision is associated with decreased depth perception because it's usually targeted in one eye. Maybe better served with a newer lens like monofocal plus, like by Enhance, by J&J, EDOF, or multifocal IR technology. So these lenses are best for the patient who has a central scotoma, whom we know that they might progress, and the patients with pseudoexfoliation and weak zonules, whom we might be using CTR intraoperatively because there is a future risk of capsular contraction and the lens will descend. EDOF lens is highly noticed subject in ophthalmology, you can say. So EDOF lens are new category of presbyopic correction lens. They took over multifocal lens in all range because they have less of a photic symptoms and they don't affect the contrast very much. So it is to be offered to the patient whom you know that it might not progress. It's not that it won't progress, it might not progress. So the most common or most beautiful lens is VVT according to the literature. So it has shown that it is performing equal to the monofocal lens with the advantage of intermediate and near vision. So we can give this to moderate glaucoma. Multifocal lens is not a strict no to the patient, but we have to be very careful while giving it to the patient because it is associated with even the newer multifocal lens or trifocal is associated with decreased contrast sensitivity. So the patient will complain of photic symptoms. This lens is to be used with very caution. Toric lens is very commonly used, or not very commonly, but it can be used very comfortably. The patients with glaucoma have astigmatism, and even small correction of astigmatism will definitely help the patient. And these patients, the toric lens is usually used for astigmatic neutral mix and combined cataract surgery, but we have to be very careful while using for small pupils and zonular weakness because we might have difficulty in dialing the lens as well as the future capsular contraction may lead to again refractive changes. So the most important take-home message is do what's best for the patient and explain the patient that glaucoma is a progressive disease. It's not that we can't give them premium lens, but we have to be very careful explaining everything, and this date we have to also take a written consent from them.